Dr. Mehran, Pakistan is made up of 5 provinces. The second largest province is Sindh, but it's also called Mehran. So we have named the province after you. Welcome.
Thank you, Professor Faruqi. It's really an honor and a pleasure for me to represent the American College of Cardiology at this wonderful meeting, and I feel very honored to be included in this forum with all of the professors, my colleagues, my friends in Pakistan. As you know, I'm originally from Iran, your neighbor, and my father made a lot of trips to Pakistan during his service back in the 70s, and I remember many, many times when it was his favorite place to visit, where he received the best and the friendliest welcome from the Pakistani people. So it's wonderful to be here with you. Thank you for having me.
Dr. Mehran, welcome to your second home, and without further ado, let's hear you talk on the acute coronary syndrome.
So this evening, for you and this morning, I thought we would talk about acute coronary syndromes and to give you an update on diagnosis and management. These are my disclosures for all of the clinical trials that I run at Mount Sinai. As you know, I have an academic research organization, and my center is responsible for multiple clinical trials in interventional cardiology and also general cardiology. I want to first start with the 4th universal definition of myocardial infarction, because there are important new concepts in the definition of myocardial infarction that we should really be understanding. And we're hearing a lot, especially now after the EXCEL and ischemia trial, a lot about myocardial infarction, peri-procedural, post-procedure, and presentation, and spontaneous myocardial infarction. And let me just make sure that there are new concepts now in the universal definition where there's a differentiation of myocardial infarction from myocardial injury, highlighting an important difference between myocardial injury after cardiac and non-cardiac procedures as discrete from myocardial infarction. So it's important to note that. So beginning with the diagnosis of a myocardial infarction, obviously these 4 pillars are always there for all of us in clinicians, but the ECG is incredibly important, and the guidelines talk about that in STEMI, the 12-lead ECG being one of the most important parts of recording and interpreting myocardial infarction. Maximum target delay of 10 minutes is what is asked for as soon as possible. And then, of course, having defibrillator ability there for suspected myocardial infarction. And of course, we all know that this is where we are with the ST elevation, making an important decision whether there's non-ST elevation versus ST elevation myocardial infarction, because there are different treatment modalities for those. Because in non-STEMI, obviously, it's still class 1 indication to go forward with a quick emergency arrival and getting the patients into a 10 minutes of an ECG, and then the serial ECGs are 15 to 30 minutes. And the continuous monitoring is actually interesting. It's a 2B recommendation. Cardiac biomarkers are very important. Obviously, class 1 indication to rule in and to rule out. And the high sensitivity troponin assays is what's being measured mostly in the United States, and I think now around the globe. And then, of course, there is this rapid rule out, rule in protocol at 0 hours and 1 hour recommended if there's a high sensitivity troponin test validated. I think it's also important to have an important risk assessment. There was this Compass MI project risk assessment where they looked at patient level data in close to 23,000 patients, coming up with a risk assessment tool that actually integrates troponin on presentation, dynamic changes with serial sampling, and the time between and obtaining these samples. And of course, this rapid TNT study was very interesting with a randomized trial of 33,400 patients, standard care versus intervention, where this rapid triage strategy was very, very safe and was able to rule in and rule out patients without an important poor outcome on the patients who got ruled out. And then, of course, we saw at last year's ACC the presentation of this very important trial, the historic trial. It was a single troponin testing where there was a suspected acute coronary syndrome patients in over 31,000 patients, and this population had a rapid rule out versus a standard rule out pathway. And it was interesting, they weren't able to actually show that there was non-inferiority in terms of MI and cardiac death. They didn't meet that criteria, but the rate was numerically lower for those patients who had the rapid rule out. So once we figure out that we made the diagnosis and rule in myocardial infarction or an acute coronary syndrome, where are we with management? Well, PCI, I think there's no question that has been, after 16 years of having Dynami study presented PCI versus fibrinolytic therapy showing that PCI is superior. And there's no question that fibrinolytic therapy is inferior in terms of obviously intracranial hemorrhage, stroke, and there are important contraindications, obviously, to fibrinolytic therapy. But most importantly, it has to do with the fact that PCI, when you have ability to get the patient to a PCI center, that is the way to go. And then, of course, then fibrinolytic strategy comes into effect, and I'm going to let Dr. Wilson give you those data when he's presenting his late presenters. I'm not going to talk about that today. This is the Dynami 2 16-year follow-up showing the importance of and the superiority of primary PCI 16 years out compared to fibrinolysis. The benefit stays and is maintained over the full period of follow-up of these patients. So when you can, and if you can, please refer the patients for primary PCI. Very, very important. Then the other thing is this door to balloon time. We've done a very, very good job in reducing door to balloon time. And as we did, the door to balloon time reduced over the last couple of decades in over 100,000 patients. This was published in 2013. And it was really upsetting for me to see the flattening of the curve in terms of mortality. Mortality has not changed. Reduction in mortality has not changed, even though we've reduced the door to balloon time, which begs the question, we need to go outside of the hospital and get to the patients and get them quicker from the symptom of onset into the hospital. And then once they get in, we've already done a great job in reducing door to balloon time. And still, if you can see here, for the recommendations for optimal results is really for getting if there is fibrinolysis or whatever it is, you have to train and equip and identify STEMI. It's recommended to get the patient to a PCI capable centers. And then of course, very important that there is a bypass of the emergency department. Get the patient straight up to either CCU or to the cath lab directly. And that's really been able to cut down times. What about where we are in terms of access? What do we do when we get the patient and immediately get them to the cath lab in acute coronary syndromes, radial versus femoral? And I think there was no question this was the MATRIX trial, large numbers of patients. This was presented a couple of years ago. Radial access gives you a consistent benefit across the spectrum of patients with acute coronary syndromes in terms of reduction of all-cause mortality, MI, and stroke, and furthermore, a very important and most important reduction especially in the STEMI patients, in bleeding complications, and also both in STEMI and non-STEMI, there was a big reduction in bleeding complications, and you can see the reduction of all-cause mortality, MI, and stroke, very prevalent in STEMI patients when possible. What about in non-STEMI? What's the optimal timing? Well, the TIMAX study has shown in a large numbers of patients, over 3,000 patients, let's go to quickly over 24 hours versus just a little bit delayed above 36 hours in non-STEMI. I think we know STEMI right away, get them to the cath lab. What about non-STEMI? Can we wait a little bit? It all depends on the risk of the patient. If you have a high-risk patient, the overall risk of a patient, the underlying risk is what is extremely important. And what it means is that if you have a high-risk patient, an early intervention is very, very impressively important. The low to intermediate risk patients, you can wait a little bit, you can go up to 36 hours. But when you have high-risk features, dynamic STT wave changes, symptoms that are not being relieved, and hemodynamic changes, you gotta go quickly to the cath lab and reperfuse that patient. What about the non-infarct related artery? As you know, this is a very, very important issue that has been brought up. Used to be harm in the past in 2013. We were very, very adamant that PCI should not be performed in a non-infarct related artery. We came up to a 2B in the focus session of in 2015, and really this was a modified recommendation to a 2B because of these trials, Dynamic 3, Primulti, and Culprit. And important to note that the European guidelines gave it a 2A. After all of these data, they upgraded it from their previous study because of these randomized trials. And you know that these randomized trials showed that there was a reduction. They were all small, but there was a reduction in ischemic endpoints of the patients who had complete revascularization, and they had multi-vessel primary PCI, and this was in hemodynamically stable patients. The PRAMI study is one of the first studies that actually looked at this. This was a study of patients with STEMI undergoing infarct-related artery PCI, and they did go to the limited to the infarct artery, or what they called preventive angioplasty, in angioplastying the non-infarct related arteries in the same setting, and they showed a very big reduction in their in the composite endpoint of the primary endpoint of cardiovascular death, MI, and refractory angina. And then this was really, we always said that was an underpowered study, but really this, the biggest study, the most important study that I believe wholeheartedly will change the guidelines, most likely to class 1. We don't know that, but it should happen, because this is over 4,000 patients. We just presented this at the European Society of Cardiology. STEMI patients, 4,000 patients evaluated at the time of PCI when they had multi-vessel disease. They were randomized to a complete revascularization, and this wasn't at the time of PCI because patients were randomized after the culprit vessel was intervened, but it was at complete revascularization within 30 days after their STEMI, or either a staged or in the hospital, versus the culprit lesion only PCI and then watching for symptoms. The patients who had complete revascularization had a reduction of cardiovascular death and MI. That was a very, very important co-primary endpoint of this study, cardiovascular death and new MI, and of course the other primary endpoint was the cardiovascular death, MI, and revascularization, which was also positive. But I pay attention to this very, very important endpoint, hard endpoint of cardiovascular death and MI. There was a major reduction, a 26% reduction in new MI and cardiovascular death over a 4-year period, which was durable. And as you can see, look at those curves in the small, in the blown up session. You see the curves are separating over time. In fact, the benefit is coming a little bit further, such that complete revascularization patients They separate right away within the first year, but take a look, it's actually separating even more. And we also looked, and this was presented at TCT, that the timing of the complete revascularization didn't matter. Whether it was in the hospital or outside of the hospital, as long as it got done in the first 30 days, 30 to 45 days after the STEMI, there was a very, very big benefit for these patients. So it was okay to send the patients out, but it needed to come in, and these patients did need to come back and get their revascularization within 30 days in a staged manner. And you can see that this was, I believe, is a changing of our guidelines based on this trial. But it is important that this is not the same in every single scenario. Now, in the past, the shock trial did show, by Judith Hochman a long time ago, did show that you should do revascularization. Well, Holger Thiel and his team actually randomized over close to 700 shock patients. These are really difficult studies to do. And what they did is they said complete revascularization, multivessel PCI in cardiogenic shock versus just taking care of the culprit and getting out of the cath lab. In this study, it was completely different. The patients who had multivessel PCI at shock actually had a higher rate of their 30-day risk of of death, all-cause mortality, and severe renal failure. That was the co-primary endpoint, and it was worse for multivessel PCI. So in shock, it's a different story. And I think we really need to sort this out. When you have hemodynamic compromise and cardiogenic shock, it seems that it's best to just take care of the culprit vessel and then go on if you want to, especially on the renal failure and death episodes. What about the pre-hospital antiplatelet therapy and STEMI? This is a very big subject of situation that I think we're going back and forth. The ESC guidelines in 2018 actually recommended, of course, aspirin, and they're saying a loading dose of a high dose, which we also agree with. In our guidelines, we say chewable aspirin immediately. There has to be given initial loading dose, no matter what they were on. They need to get a chewable aspirin, 325 milligrams. But then they also say a potent P2Y12 inhibitor is recommended before PCI and maintained over 12 months unless there's a risk of bleeding. This is interesting because it's in contrast to some of the reloading studies, but they believe that this is incredibly important. For non-STEMI, the management is very, very different. It depends on the risk of the patient. The very high-risk patient gets an immediate invasive approach, less than 2 hours. The high risk gets less than 24 hours, and the intermediate risk, that which would be a patient with diabetes, chronic kidney disease, post-infarct angina, race risk score more than 109 but less than 140, recurrent symptoms on non-invasive testing, they get about greater than 72 hours. And this is really, really important because I just presented the data to you. I love how the Europeans do this level of really looking at the risk and not one size fits all for all non-STEMI, and this is really, really important. What about CABG versus PCI in non-STEMI patients? There's very little data here, but this particular trial is data pulled from 3 randomized studies: Syntax, Combat, BEST, 1,246 patients presenting with a non-STEMI. They had multivessel disease, and you can see here that the difference of MACE, there is a difference of MACE, and you can see that CABG does better than PCI in this is a reduction of the rate of the myocardial infarction. And I always say the devil is in the details because this was a primary outcome of death, MI, and stroke. The reduction was all from less MIs, but remember in these studies, CABG didn't really look at MIs, peri-procedural MIs were different. And so it's very, very important to note that I believe that it all depends on the patient and on the center and what kind of lesions and date and syntax score you're dealing with, and what are you seeing in front of you to make a decision, an informed decision about PCI versus CABG in patients with multi-vessel disease to get them a complete revascularization. And you can see here that this is the multi-vessel disease, and you can see right here that the benefit is all in the high syntax score patients, and even maybe in some of the left main patients that present with a non-STEMI. Let me go back again to the PPCI antiplatelet regimen. They are giving this recommendation of the potent agent, prasugrel, in P2Y12 naive patients, or ticagrelor, whether or not you're on a P2Y12 regimen. And then, of course, clopidogrel is given if you don't have those two agents available, to give the double dose clopidogrel, 600 milligrams, only if you are not available or contraindication prasugrel and ticagrelor. What about the intra-procedural anticoagulation, bivalve versus heparin? Well, I think, as you know, I spent a whole decade of my life working on bivalirudin studies. We showed a reduction in bleeding, but it was always against the P3A inhibitors. There was no question that if you give bivalve, you can reduce bleeding, but most of it is secondary to the fact that the comparator had GP2B3A inhibitors. But the risk of bivalirudin, if you're not having it, no P2Y12 on board, good potent P2Y12 inhibition on board, which is what we had, there was an increase in rates of stent thrombosis, and that's the trade-off. And I think it's important that now I think bivalirudin is a judicious use when heparin is not available, or there's HIT, or you're dealing with a patient who's at a very high bleeding risk and you want a consistent and a short-acting drug, but otherwise heparin is what is there. So just to go back on the P2Y12 inhibition and what we're doing, and this is basically from the guidelines, the DAP guidelines that we did, class 1 recommendation for 12 months of an acute coronary syndrome, no matter what the patient ends up having. So whether you do CABG, PCI, medical therapy, lytic therapy, whatever you do, this patient will require 12 months of dual antiplatelet therapy. But now this is going to be revisited after we just presented the Twilight study. But the maintenance, as you can see here, for the guidelines in patients with an acute coronary syndrome, as much as you can, is 12 months, unless you have a high bleeding risk. And here, they use the precise DAP to evaluate those patients. In those patients who have a high bleeding risk, you go down to a lower level up to 6 months and even up to 3 months when your bleeding risk is very, very high. And I think that's an important piece, and you could de-escalate as well. The update in DAPT in 2017, the new recommendations for the European Society, and the change in recommendations are there, is really actionable bleeding is very, very important to reconsider the DAPT regimen. It's important to think about bleeding much, much more. There is a liberal usage of PPI to mitigate GI bleeding. Decision of the duration is dynamic for DAPT. You have to take a look at the patient at different times. You can discontinue when you have a high bleeding risk, as I discussed. The ticagrelor interruption before surgery is about 3 days, as opposed to where it was 5 days. Elective surgery, that requires discontinuation after a month, is now getting a little bit of a 2B recommendation, if you can say, or a 2A recommendation as you need it. I think it's important to take a look at these and understand them. The revised concept is that we now are going completely to a drug-eluting stent. Bare metal stents are out in patients who are at high bleeding risk, even with an acute coronary syndrome, especially with an acute coronary syndrome. You can use risk scores to evaluate the risk of the bleeding, and you have to understand in complex PCI what that is, and what are you doing with anticoagulation and DAP, and the dosing regimen. And at the end of the day, it's all about the balance, as you know. Currently, there are several risk scores. There's GAP and the precise GAP score that has been mentioned in the guidelines. But I want to also give you the parents' risk score, which we
Sorry,
developed.
Dr. Mehran, sorry, you're very close to the to your time ending.
Okay, I just want to finish to let you know that, let me just tell you that, I thought I had 45 minutes, so I'm sorry. But let me just tell you where we are. Let me just give you this one piece on Twilight, if I may. Is that okay, Professor?
Yeah, I think if you could
Okay.
conclude in half a minute.
Absolutely.
And I have a request for Dr. Wilson. The technical staff tells me you have to rejoin again. There's a technical hitch so that you are already online by the time Dr. Mehran ends. Please. Can I request Professor Sohail Aziz, who's so diligently put together such a fantastic meeting, to say something in the meantime?
There's a lot of data, sir, to suggest that, in coronary heart disease, we need to separate the acute syndrome with the stable coronary artery, and which has now been defined as chronic coronary artery disease, chronic coronary syndrome. The data which is raising so much controversy is the stable angina. We was reading about the ischemia trial now, and we read about the courage trial earlier. But there's no doubt that whenever we deal with these, you divide these the whole spectrum into two: acute syndrome and a stable syndrome. And the data is very overwhelming that in acute syndrome, it is the early response which is very beneficial, and that's what we saw in this data, that earlier the better. But once you get the balloon time below a certain limit, there's no further benefit in reducing the door time less than 50 minutes or whatever. That is the reason they say the next thing which will help reduce the mortality in acute MI is to get the defibrillator to the patient as quickly as possible. That's why they suggest that you should not drive to the emergency. You should call in 911 emergency response so that the defibrillator comes to you earlier, and that you do not have to go through a check post or whatever. They drive you straight into the cath lab. So that is one thing. And similarly, in non-ST MI, the earlier this intervention is done, the better it is. About the antiplatelets, we've got these wonderful new antiplatelets going on, but bulk of the data is, we've got all the things right. So it's the time which is of essence into.
Thank you, Dr. Sohail Aziz. We've got Dr. Ruxana back on the line. Dr. Ruxana, can you conclude in 30 seconds? We don't have her sound. Dr. Mehran, we've lost your sound. I think time is running out. And we would like to thank you for your excellent talk, and would like to now welcome Dr. Wilson to his talk on management of late presenter STEMI cases. Is he on the? Dr. Mehran, we move on to Dr. Wilson. Any concluding remarks?
Can you hear me?
Yeah, I can hear you now.
Okay, can you hear me now?
Yeah, I can.
Okay, can I just summarize and I'll leave? And I think what we just heard was excellent, that obviously there are new ways to get diagnosis of myocardial infarction quickly. Let's get to the cath lab quickly, as you said, use the potent agents, complete revascularization in multivessel disease, and now we have a new strategy of dropping aspirin, even in ACS patients when you have a potent agent on board, and that's from the Twilight study, which we published in the New England Journal, and we just published this at AHA. We just presented this at AHA in acute coronary syndrome patients, where you could do the same. Thank you for having me. I'm sorry that I went over time.
No, thank you. Dr. Wilson, You are on from now. You have 20 minutes from now.
Thank you. I am trying to now pull up, there we go. So thank you, Dr. Faruqi. Thank you, Dr. Iqbal, distinguished panel, and all the members of the Pakistan Cardiac Society. Thank you for having the ACC join you again this year, and I appreciate that you have asked me to talk about late presenter STEMI cases. Can you hear me?
Yes, we can.
Great. Thank you so much, and good evening, and enjoyed very much Dr. Moran's excellent presentation, and I will try and proceed with late presenter STEMI cases and the management of these patients. So I have no financial disclosures. So Dr. Moran actually gave great introductory slides for my own talk, and I won't dwell on these, but I think the overall theme of both of our talks is time is of the essence. And we know that, as she said, that the first 4 hours are key for maximal myocardial salvage after acute STEMI, but that we also know that there is some improvement and some salvage even up to 12 hours. It's been well shown. But also, actually, the topic of this discussion is what happens beyond 12 hours and what is the benefit of late presentation STEMIs having reperfusion, and particularly as relates to an open infarct related artery. So again, I'm not going to go over these basic fundamentals that Dr. Moran outlined, but as she said, it's very key to expediently get patients to the cath lab for PCI whenever that's possible, and also then, if not, to think about timely thrombolytic therapy and then destination therapy to a center that can follow up with cardiac catheterization and PCI when indicated. And again, she showed this slide of the recommendations that I think we all know, which really, again, dwell with class 1 recommendations to train and equip systems of care and ambulance systems and speed patients as quickly as possible with a routine updated STEMI management protocol to the cath lab expediently when possible, but if not, then to think about timely thrombolytic therapy. And again, she showed this slide of important time targets. And again, these are ideal time targets. As you can see, getting the patient to PCI within 120 minutes, or thrombolytic therapy to be administered in less than 10 minutes if there's a decision that the patient cannot get to the cath lab within 2 hours. And then the very last row, time delay from start of fibrinolysis to angiography, even if it's successful, allows for catheterization within the first 24 hours and then definitive therapy thereafter. But again, the subject of this talk is really what do you do with those patients that are beyond the 12-hour time limit? These are the late presenter STEMIs. And in the past, these patients have probably had not as much attention as the early presenters, because we know that, again, in the early hours, we have our maximal gain. So the question is, do we have benefit even beyond 12 hours? And particularly in studies to date, there hasn't been really much in the way of data that supports that there's any mortality benefit beyond 12 hours. And I'm going to go through some additional studies that touch on that. And as she also pointed out, there may be increased harm for those late presenters that then get fibrinolytic therapy in terms of potential intracranial hemorrhage. And then also we know that late presenters have not been included in trials showing superiority of primary PCI over fibrinolysis. And again, those were usually early presenter patients less than 12 hours. And I highlighted a few of these studies over the last 20 or 30 years that, primarily in Lancet, that spoke to this subject. So again, the late presenters is definition is those that are presenting more than 12 hours after the onset of STEMI. We don't know exactly the percentage of these patients from various studies, but it can be as few as 8.5% all the way up to 40% of all STEMI patients that can be presenting past 12 hours worldwide. We do know from the CREATE registry in India that they had more than 30% of their STEMI patients that presented after 12 hours. So it's a significant group. Somewhere around 1/3 to 40% of patients are late presenters for STEMI. So what are some of the factors that are related to this large group and why they don't receive reperfusion therapy expediently? Well, certainly we talked about the basic definition that they're a delayed presentation. And oftentimes, in addition, the elderly group, less than 75 or greater than 75 years of age, or if they've had complications and complicated history in the past, like heart failure, previous MI, or previous bypass surgery. We do know, unfortunately, that female gender has been less well served in the past worldwide in terms of optimal therapies. We also know that diabetic patients are a complicated group, and oftentimes because of complications may not receive expedient STEMI therapy. And then of course the patients may be so complicated that you may actually increase their risk in terms of whether or not they present with pulmonary edema, they're hypotensive or in shock. And also we do know that there's spontaneous reperfusion in about 11% of patients as well that do not require additional therapy. So there's various theories about the benefits of an open artery, so-called open artery hypothesis. And as I showed you on that first wavefront slide of experimental of myocardial infarction, we do know that there is a wavefront phenomena and there is a gradient of flow reduction throughout, but there is some flow in various parts of the myocardium even after infarction. And there can be gradual recovery of this myocardial blood flow, maybe even as much as twofold, even up to 96 hours after coronary occlusion. We also know that there can be anaerobic glycolysis and free fatty acid metabolism, which starts with reduction in coronary blood flow down to 20% of normal. And that there can be intermittent patency of the infarct-related artery also, so-called stuttering infarctions, and that can occur in up to 30% of patients inside of 12 hours, and maybe half of all patients can be stuttering infarcts between 12 and 48 hours. And then we have also this low flow ischemia process, this so-called stunned or hibernated myocardium with the stuttering course of the STEMI. And there can be presence of collateral circulation and even with this some ischemic preconditioning, which actually may be protective. So overall, what we know or think is that the infarcted myocardium is a highly dynamic tissue, and it's not simply dead, nor is it inert. And so this may be a frontier that we need to continue to explore to help with outcomes and salvage our patients. So furthermore, if we think back with one of our major leaders in the past, Dr. Braunwald, back in February 1989, he said an open infarct-related artery may be beneficial by preventing LV dilatation and improving survival by limiting infarct size and associated deterioration of LV function. And this can occur through prevention of adverse LV remodeling, electrical stability, and also allowing collaterals to the remaining viable myocardium. So some of the proposed mechanisms underlying this beneficial effect of late perfusion and the effects on infarct tissue, it may accelerate infarct healing. There also may be some reduction of the collagen degradation and preservation of the non-myocyte cell component. So there actually could be accelerated healing as well as suppression of apoptosis of the granulation tissue cells within the infarcted myocardium. And there can also be some awakening of the hibernating myocardium and myocytes as well as, again, reduction in apoptosis or cell death. So BRAVE 2 was an important study. It was a randomized controlled trial of mechanical reperfusion in patients with acute MI that were more than 12 hours from their symptom onset. So this is the exact target group we're talking about this morning. This evening. They looked at 365 STEMI patients 12 to 48 hours after onset that did not have persistent angina or symptoms. They excluded the patients that were in the higher class heart failure groups 3 and 4, and then they randomized them to PCI or medical therapy. And then the primary endpoint was to look at the LV infarct size at 10 days by SPECT, and then secondarily look at true outcomes, death, MI, and stroke at 30 days. And what they found, this was presented several times in 2005 through 2009, that the LV infarct size in the PCI group was 8% versus 13% in the medically treated group. So it was significantly less for those that received PCI late, and the 44% area of risk was salvaged by PCI versus 23% by medical therapy. So almost double the area salvaged by PCI, even in these late presenting patients in BRAVE 2. And then furthermore, when they followed these people out to 4 years, you can see that in the invasive group in BRAVE 2, that there was almost a 50% reduction in their mortality over time in those that were treated aggressively with PCI, even after 12 hours of presentation from STEMI. And then if we look at the Polish study of reperfusion of PCI in patients with STEMI 12 to 24 hours after the onset of symptoms, which was presented back in 2011. This was the Polish registry. They were real-world ACS STEMI patients. They had over 2,000 patients that presented 12 to 24 hours after symptom onset. Again, they excluded the higher risk heart failure shock patients, class 3-4. So about half, 910, were treated by PCI and 1,100 by medical therapy. And the primary endpoint was all-cause mortality at 1 year. And again, you can see that they had a significant reduction in mortality for those late presenters that were treated by PCI after set the tone for the last couple of decades for these late presenters, of course, is the OAT trial, the occluded artery trial, again by Dr. Hockman and colleagues. And this was, again, almost now 15 years ago, of over 2,000 patients. These were even later presenters, 3 to 28 days after symptom onset, and they had EF less than 50% and or proximal large vessel occlusion. However, they excluded again the class 3 and 4 in the left mains and triple vessel disease. And their primary endpoint was a hard endpoint of death, MI, or class 4 heart failure. Now, this again is probably what set the tone so far, was that it was a negative study for any significant effect for the PCI group versus medical therapy. In fact, they were slightly higher for the significant complications and mortality even out to 5 years. So this was negative for late treatment, and you can see here divided by death, fatal and non-fatal infarct, non-fatal reinfarction, and class 4 heart failure. None of these showed any improvement with the late treated PCI group versus medical therapy. However, although there wasn't any mortality benefit versus medical therapy, even in the patients that were treated 3 to 7 days from onset, there was significantly less angina that was shown at 7 years, and repeat revascularization was significantly less at 7 years. So one might say that although this really suggested there was no benefit for this late group being treated invasively, there were at least a glimmer that perhaps there was less angina and repeat revascularization when followed over time. Now, there have also been major critics of the OAT trial since then. One was that they had a long exclusion list that perhaps was not representative of real life ACS and STEMI patients, and that they did have slow enrollment, only 2 patients per center per year. So the question is whether or not this again was a good representative sample of what we see in the real world. The other was that the median time to revascularization was not just late, it was very late. It was 8 days post-STEMI. And again, that raises the question, is that really too late for benefit? We're not talking about revascularization at 12 to 24 hours or even inside of 3 days. We're really talking about a median time of 8 days, more than 1 week. And again, maybe any benefit was lost by that time with early revascularization. Interesting, just if you look at it since that time, about 5 years after this was presented, at least in this evaluation in the US, as you can see in that upper right-hand corner, there really was no change in the US in practice as far as doing late PCI versus reduction in people doing PCI after 3 days. You can see that it still was a significant part of practice in the U.S. In the early part of this decade. Also, cardiac mortality increased as the left ventricular ejection fraction decreased below 40%, but in the OAT population, only 21% actually had these lower EFs, so it may have been difficult to really show, again, improvement with revascularization in this perhaps lower risk, higher EF group. And also, as we know, in general, inferior infarcts and right coronary occlusions are better tolerated than those in the left coronary, but inferior infarcts and right coronary occlusions were nearly half of the patients, so one might say that this was a lower risk patient population, and so therefore difficult to show that revascularization made a difference for these late presenters. There's some other studies, 10 randomized controlled trials of put together for survival and cardiac remodeling benefits, a meta-analysis that Abadi and others did, and again, about 10 years ago. And what you can see is that in this meta-analysis, and if you look down the left column, you can see a couple of the studies we talked about, BRAVE2 and OAT, and what you can see is that it did in this meta-analysis suggest that PCI was favorable for reducing mortality for these late presenters, and also that there was an improvement in ejection fraction for these late presenters that were treated with PCI, and also the combined endpoints of death, non-fatal reinfarction, or hospitalization, rehospitalization for angina and heart failure were also favoring PCI in these late presenters. So, lots of data. What are the guidelines as they stand today? So if we look at the ACC-AHA guidelines from 2013, you can see that it's a class 2A for delayed PCI of patients that's reasonable and stable patients with STEMI after thrombolytic therapy, ideally within 24 hours, and probably after the first 2 to 3 hours after administration of thrombolytic therapy, but not before. Now, it's the class 2B for the delayed PCI of a significant stenosis at a patent infarct artery greater than 24 hours after STEMI. Again, this is a patent infarct artery, so that may be of benefit, a class 2B, but still it's a class 3 of no benefit for a totally occluded infarct artery greater than 24 hours, and this is particularly in patients that are no longer having any symptoms. Now, the European guidelines from 2014 I think are a little more articulate in that they say it may be a class 1 indication after 12 hours, particularly if these patients are showing signs of continuing ischemia, life-threatening arrhythmias, chest pain, or ECG changes that suggest stuttering infarction, and also They even state that it may be a 2A for reperfusion therapy with primary PCI for the late presenters 12 to 48 hours after symptom onset. So this is supposed to be about late presenter STEMI cases. So I think I have a really unusual, perhaps interesting one that was shared with me by Dr. Fong, who is the chapter governor for ACC Malaysia, about a native lady in her 50s with no known medical illness. She developed chest pain around midnight on a Friday there. Her village was upriver from the nearest district hospital, where she could receive thrombolysis, which was Caput Hospital. But as it was dark, there was no one to bring her down at midnight. So the only method of transport was being by a longboat downriver. So at sunrise, the boatman took her downriver to Caput Hospital, still conscious but still having chest pain. And this was well over 6 hours at that point. When she arrived at the boat jetty in Caput, she suffered a cardiac arrest. She was given bystander CPR at the riverside and quickly brought to hospital, where she was diagnosed with ventricular fibrillation on the cardiac monitor and promptly defibrillated. She subsequently became hemodynamically unstable, requiring inotropes, and then had another VF arrest, which she was again defibrillated. A medevac helicopter was dispatched, brought her to Kuching, where she received at lunchtime. So this was well over 12 hours, brought straight to the cath lab, successfully had PCI and stent of a subtotally occluded right coronary dominant vessel, recovered and went home 4 days later on Thursday, and that was in Borneo in the Sarawak province in Malaysia. Here's the longboat that she was transported on supine downriver overnight to the early morning hours. And this is a map of her journey, which was 1 hour by longboat, but again, this was after a 6 hour delay, and then 1.5 hours by helicopter to get actually definitive therapy, and a great save by Dr. Fong and the team in Malaysia. So again, how do we deal with these late presenters? This has been presented for a while, this international reperfusion strategies and STEMI. And again, on the left column is their standard, treatment to get primary PCI within 60 or 120 minutes, depending upon presentation site. But if we go down the right arm, you can see for those patients that are unable to get PCI less than 120 minutes, if we can think about getting thrombolytic therapy there expediently, and then a transfer, hopefully in a little less emergency fashion, unless they need rescue, and get definitive catheterization within the next 24 hours, the so-called pharmacoinvasive PCI approach that's been popularized by Armstrong and the STREAM investigators and FAST-MI and many other groups. I think that would be the way to go. Let me give you one more study before the summary, which came out last year by the Nefer-Christensen group in circulation. And interestingly, they looked at the early presenters less than 12 hours versus those in 12 to 72 hours. And they used cardiac MR to look at the percentage of patients in terms of the area at risk, and we're able to then evaluate that with follow-up and develop a so-called salvage index. And what you can see on the left side is that obviously within the first 12 hours, the 75% blue, or 3/4 of patients that had a large amount of salvage presenting early. But I think importantly on the right, you can see that even in the ones 12 to 72 hours, the salvage was, nearly 2/3, 65% by this study done with cardiac MR. So this is one of the latest studies in this area, and I think it speaks strongly to the fact that, this cutoff at 12 hours may be arbitrary, and that we really need to rethink these late presenters and possibly what we can do for them. So in conclusion, I'd say timely reperfusion with percutaneous coronary intervention within 12 hours of symptom onset is the first choice treatment in STEMI patients. But as I showed you in various studies, up to 40% of patients of all patients with STEMI can present later than 12 hours after symptom onset. So we need to think about reliable therapies to shore up this group. The effect of primary PCI in STEMI patients with signs of ongoing ischemia presenting later, 12 to 72 hours after symptom onset, is unknown, but several studies suggest that this may indeed be beneficial, and more beneficial than we have previously thought. So I hope I didn't run over too much, but thank you very much for your time and attention this evening. And once again, thank you for allowing the ACC to share in your important meeting here today.
Thank you, Dr. Wilson. It was a treat to hear you put together the data for us on this very important subject. We are out of time for questions, and thank you, and thank the ACC, and thank the person in the background, Stephen, if you can hear me, thank you. With that, we come to the end of the live transmission. We have our faculty here. I would like that each one of them give a very brief 30-second concluding remarks, starting with Dr. Sohail Aziz.
Thank you, sir. I think when you talk of reperfusion, there are two ways of reperfusion. One is the thrombolysis, other is the primary PCI. So if you go beyond thrombolysis, beyond 12 hours, then after 12 hours, the incidence of intracellular hemorrhage increases to the point where you end up killing probably equally or more number of people after 12 hours. But when you do a primary PCI, the benefit of thrombolysis starts to come down with time, and the first hour is as useful as primary PCI. But after first hour, the benefit starts to drop. But in terms of primary PCI, the advantage is maintained. So I think when you in that area, one should still stick to the situation with on the evidence of ischemia in terms of chest pain or ECG changes. But that's one aspect. The other aspect is very important to define the anatomy. And you can, define the anatomy, even with the ischemia trial, we found that although they talk of against an intervention, but they were visualizing the anatomy with either a CT scan or a thallium for ischemia. So you have to stratify these people, even if they're latecomers, what kind of risk stratification do they have? Is it single vessel disease which is included, or they're multi-vessel? And I suspect that huge number of three-vessel disease. So if you wait for somebody who's a breadwinner, who's come with acute MI after 12 hours, you say you're going to spend some time till we restudy, looking for evidence ischemia. So till you do all these things, he's going to be out of his job. And if you're going to offer him bypass, his recovery will be delayed much further. So my personal opinion is that once these guys get admitted, I would reperfuse them, of course, based on ischemia. But I would study them invariably to realize what kind of anatomy and what kind of extended disease he has.
Thank you. I think before we go to the next chairperson, I think what Dr. Sohail mentioned, I think all of you must, if you have not already done so, go and study the ischemia study presented at the American Heart Association last week, just a few days ago. I think that is an earth-shaking reconfirmation in many ways and new knowledge over the previous trials that we've had. I think we're going to be discussing this study a lot in the future. I think we can go down.
Just a small comment on the ischemia trial, sir. Nothing which comes out in the New England Lancet or out of ACC changes my practice. And I think you can find a lot of flaws in that trial, although I suspect it will become part of the guidelines based on how widely spread it is and the power of the study. But I think there's nothing new in that study as far as I'm concerned.